continue with our program now, more on meaningful use, stage 2, from this time from a functional and operational standpoint, with Linda ClenDening, also with PYA. She is a manager. Linda has 25 years of total healthcare experience, all of which have been focused on the physician practice management. Linda has been employed by PYA for 2.5 years. Prior to joining PYA, Linda was employed by Premier Orthopedics and Sports Medicine in Nashville, Tennessee. Linda has a Master's of Science in Information Systems and Project Management. Linda's recent project work has included operational and financial due diligence for physician practice mergers and acquisitions, facilitation of the selection process for a billing services vendor for a large physician group, project design for bringing business operations in-house for a regional network of clinics, and our all familiar PQRS readiness evaluation of physician-owned practices for a large integrated delivery system. Please welcome Linda.
Thanks, Paul. Thank you, Paul. Good morning, everybody. I appreciate your time today, and wanted to let you know I'm in from Nashville, Tennessee, where I understand we're going to get snow and sleet tonight. So I'm glad I'm here in your sunny state. Really appreciate it. I really get to springboard from a lot of what you've heard so far this morning from a regulatory perspective, and also from really great information, I thought, from the audit team of what they had to go through. So I really get to springboard from that and take it a little step further and go into some operational and functional areas for stage 2 meaningful use. And when we think about operationalizing our systems that we've developed, programmers, technical folks spend a lot of time with that hardware and software. And really what operationalizing comes down to is we've got to take it to the people. We've got to share that perfect program with users. And we know that sometimes that can be a challenge. So today I want to talk about those people that are getting hands into the systems, the data, executing the meaningful use requirements, and kind of looking at in two pieces here. I want to talk about staffing for meaningful use in a lot of different healthcare settings, and as well talk about referral patterns, alliance choices, how we're different provider organizations, hospitals, as Chris alluded to, even more, healthcare stakeholders are forming partnerships and alliances, and I really want to talk about the data and how to facilitate those alliances. And a lot of what I'll be sharing with you today actually comes from you all, and I appreciate if you participated in the small survey we did prior to the meeting. We got some great feedback, so I'll be sharing that with you today. Once again, operationalizing is really about the people rather than the systems. And I had a great quote that I just wanted to share with you guys. Mary Kay Ash. I'm originally from Texas, so Mary Kay is near and dear to my heart. For those of you that know that, she's a very, very successful business entrepreneur with a makeup company. But she says, it doesn't make any difference whether the product is cars or cosmetics. A company is only as good as the people it keeps. And that's so true, and I think that that's one thing that we're really facing today in healthcare. Even in our current economic environment, it's going to be challenging for us to find the right people to continue to execute the meaningful use needs that we have. And as Chris and some of the earlier speakers alluded to, the meaningful use requirements when we're moving from stage 1 to stage 2 might not have been as onerous as we had originally thought they would be, but we're definitely moving into a higher volume of data and more complexity of data. And I wanted to share, throughout my presentation today, I'll also be sharing some information from the 2012 23rd Annual HIMSS Leadership Survey. Some of you may have seen that, be familiar with that information, but I'll definitely share with Linda a link to that information. But in that response to the HIMSS Leadership Survey, the top IT priority for the next 2 years by those leaders in the hospital, CIOs, Director of Information Systems, achieving meaningful use, focus on clinical systems, and leveraging that information. And so, it's really, the burden is on all of us, and all of you, to take this data that we're developing and using through meaningful use, and then leverage that, as Chris had alluded to in his talk. The challenging part, obviously, is that we're limited. We are human. We can only do so much. And here's two individuals who did run up against their limits quite a bit to amuse us. And just to share a quick story, I recently heard from a case study, which I found very, very interesting, about an EMR, EHR implementation, and some of the limits that they encountered. So this is a very large pediatric practice who had done all sorts of preparation and really staffed well for an EMR implementation, and they had everything ready, and they had their champion on board. Everything was going great. But they used a tool that I'll share some information with Linda about this. They used the tool to kind of start measuring, frustration level, anxiety level throughout the staff, before the implementation, during, and after, which I think is a great change management strategy, by the way. And what that tool indicated to them is that there was this subset of group within the clinic that was experiencing high anxiety and frustration. And so when they finally, but nobody was really coming forward during their, weekly project update meetings or anything to say, this is really a problem, something's not working. So they finally ferreted down, and they figured out it was this group of nurses that was having this really large amount of frustration. And what they finally found out was that during the clinical integration process, or during the interface to bring the data over from the historical system, a lot of the immunization records for this pediatric clinic, which is vital information, didn't come over. There was a problem. Something happened. And so as nurses do, and those of you in the room that are nurses, they just figured the workaround. They just figured out how to do it. They didn't want to rock the boat. They didn't want to, destroy that positive vibe that everybody had going on. So they were just figuring it out, and they were writing in those immunization or typing in whatever they needed to do. And, this is what we're running up against, is that we are dealing with people every day. They're trying to do their very best with the data and with the systems that we're giving them. But I just want everybody to kind of plant the seed of that idea, is that there's going to be pockets of challenges that we encounter as we go through these project management cycles. And I would just bring your awareness to the fact that we need to figure out, how are people doing workarounds, and can we facilitate them to not have to go there? As we think about meaningful use stage 1, maybe Superman comes to mind, I don't know. We heard a lot when we first started ramping up in meaningful use about making sure that you have a clinical champion. In the physician practice world, that tended to be kind of a lead physician, somebody that we could look to, go to. In the hospital side, I think this is when we really started to see a rise of the CMO, the CMIO, CNO, nursing informatics folks, really, really strong clinical technical people. And way back in 2006, when all this was beginning, from the Journal of American Medical Informatics Association, they had an article about the CMI being the CMIO is the new leader for health systems, and that physician leadership is critical success factor for HIT initiatives. So this was a vision that I have when I think about meaningful use stage 1. This is, a strong leader who's really going to push us through and help facilitate getting us to that stage 1. And I just kind of want you to think about that in the back of your mind as we think about, well, what's the next level? What's the next place we're going to for stage 2? At this point, I really want to introduce and get into the data that you all shared with us by responding to the survey that I sent out prior to the talk. We had a wide variety of responses from, as you can see, a lot of different facilities and types of organizations here. Primarily the focus the responders were about 50% from academic medical center, hospital, IDS, but we do have a good mixture of others. And I will tell you, I'll let you know that I also sent this out to MGMA, Medical Group Managers Association listserv that I participate in, to ask them as well, so that I could be sure to have a good blend of physician practice and hospital responders. So that's kind of give you a little bit of background. Also, just to note, earlier I referenced the 23rd Annual HIMSS Leadership Survey, and I'll share that information with Linda to send out to you all, but there was 302 responders there. That was nationwide, and that they were representing more than 600 hospitals. So we have some good data, some good feedback about IT staff and staff in general and their effects from meaningful use. So the first question that we encountered, or that we wanted to talk about, was, have you made any staffing changes, or in the past, or even currently, if you're still at meaningful use stage 1, what effect has that had? And the way that the question was asked, I kind of looked at it in terms of clerical staff, clinical staff, no staffing changes made, and other. And what really popped out, obviously, being the room that we're in, is that the other category, and we'll see this as we get further into the data, is primarily IT. So while we had the response there, which was kind of surprising, of a little over 50% said no staffing changes were made, and once again, this is just of the representative, about 45 to 50 folks that participated from this group in the MGMA listserv. The 23% indicated the other category was primarily IT staffing changes. And some of the comments that were made, we did have an opportunity for folks to insert comments, and there was really quite a good participation level there. As we saw with, Ethel and Lucy, sometimes we just got to move faster. We got to go faster. And so that's one of the things that was reported in the data, was that there's increased duties and responsibilities of the current staff, even if we haven't ramped up our staffing level. For those, and we'll get into a lot more detail about this later, but for those that did indicate an increase in IT staff, they said that the positions they were hiring for were the analysts and training staff for the EMR specific implementation, as well as quality staff, which we've heard a lot about this morning, and the importance of that. Then I asked the question a little bit differently. Okay, you've done stage 1, now maybe you're moving to stage 2. Has that dramatically changed anything about staffing? And once again, we got just about the same, numbers of response. Obviously, in terms of the comments, those that added staff for stage 1, that's not going to go away, so that's kind of maintained status quo. This was a real interesting point where the responders started talking about using consultants and looking to outside vendors and resources to provide support for stage 2. I think the level of complexity, particularly for the health information exchange component, that, particularly on the physician practice side, that was where a lot of the responders indicated they felt like they needed to look to an outside resource, that they didn't have that capability in-house. And obviously, another component there in the green in the bottom box I really found interesting was that for those that hired the quality team members, at stage 2 is where they really saw that those folks were going to need to start working closely with a lot of other IT staff members that were already on board. I will say that contrary to, this is kind of going back a little bit, sorry, on this slide, contrary to what we found on our small scale survey here, the HIMSS survey that I was referring to earlier, about 60 to 65% of those responders said that they expect a change in IT staff in 2011 and 2012. So I think maybe our smaller responder group might be a little bit outside the norm, but that was kind of more what I was expecting to hear, is that we're looking to ramp up staffing. Once again, and that's what, internally, in this small scale, we did say that we needed about 60% said new IT staff added just for meaningful use. Another thing that I found interesting in that HIMSS survey response is that historically, the top barrier to IT implementation success has been finance. You know, we just don't have the money. We know what we need to do, but we don't have the budget. This was the first year in that HIMSS survey that the top barrier that they listed was adequate staffing resources, so that they felt like they were getting into levels of information and levels of data integration that they needed to perform that they maybe not be staffed for. So I thought that was very interesting. This is the comment section about the new IT staff that's been added. Obviously, predating even meaningful use, when we were just getting started in implementation of EHR, that's when a lot of staffing ramp up occurred. And so that's what some of the comments indicated here. Also, you'll see, you know, the increased outsourced IT services and vendor services. When we asked the question about the IT staff positions added, and we gave a menu there of options of what were you really hiring for when you added new IT staff. Predominantly, report data specialist is that green bar there, the top line, and then right under that is training and frontline implementation support staff. So we've all been a part of those implementation teams where you just have to have boots on the ground, right? You've got to have people out in the other departments, you know, with the clinical staff to make sure that you have a successful implementation. So I think that's what we're seeing there. However, the third one there, the clinical data analyst, I think that ties in with kind of report and data. And now that we've got the data potential from this meaningful use implementation, what are we going to do with it? How are we going to look at it? And I just wanted to bump that up against, this is from CIO.com. I think it was back in October, they had an article about the 7 hottest IT healthcare skills currently. And you can see it really lines up a lot with what we saw in our own smaller survey. However, I will highlight number 3 and 4 there. Pretty high on their radar is project management and program management. We'll talk about that a little later, you know, in terms of the survey and information in this presentation. But I did want to, you know, basically say that EMR build specialist and then the healthcare analytics really lines up with your own experience in terms of the survey. Then we asked a question about, you know, is there some sort of nature of the functional roles of your IT staff that's changing as you progress through this meaningful use transition? And we asked about, you know, is support desk help, is that increasing the functionality of that? Is your requirement that you have liaison or networking support with outside organizations, is that increasing? And then we specifically asked about leadership and management to support strategic initiatives. And that was the largest one. We have about 36% of the small survey responders indicated, yes, that's what's happening in terms of functional role changes. And that really aligns well with something that Chris said earlier about, you know, the CIOs, the IT directors needing to be engaged at that strategic level of the organization in order to make sure the change that we're affecting at the data level is migrating into how we're operating as a business entity with our other facilities in the area. In the HIMSS survey, one thing that I found very interesting that aligned with this is that they asked the question, if the CIO or IT director is a member of the organization's executive committee, which would be that strategic decision-making body. And in 2011, 65% said yes. In 2012, 57% said yes, which not that significant of a change, but it is kind of intriguing that it's trending downwards. So I'd be curious to dig deeper into that data set to see what that indicates. And this is in the comments section, the folks that said that they were, you know, making changes in functional roles, really across the board, they said, you know, all of these things are really taking place within their department, their IT department of the hospitals. And when we think about another role change, and this gets into some of what we were hearing from the audit team earlier this morning about mobile devices, about all of the different penetration that they have of data throughout their organization, how it has to be monitored closely. This really does put a much heavier burden on your IT staff to make sure that they're monitoring, all of these things. And in fact, in the HIMSS survey, the primary IT infrastructure focus that they identified, the top 3 were servers or virtual servers, mobile devices, and security systems. So, once again, we see that within our own internal survey and the larger HIMSS survey, there's an awareness that there's a lot of different stuff out there that's being kind of brought about through this meaningful use activity that we have to pay attention to, and we have to staff accordingly. I want to talk a little bit more about some of what we saw on those earlier slides where that element of project management skill set is being introduced into, which we've had that around, I think, for quite a while, in IT departments and even in physician practice level. But I would bring the case to you that I think it's even more vitally important now, and I would like to advocate, for you as a CIO or IT director, start to encourage you to think about your IT staff, currently in terms of kind of two categories: their IT skills and their project management skills. And you may need to exercise these differently depending on what it is you're trying to execute, for your stage 2 meaningful use requirements, for your integration, or alliances with other folks. You might have a staff member that's great at your analytics and reports, and that flows very well into presentation development that you can use when you go to those strategic meetings, the executive committee meetings. But maybe you need to, assist that staff member to develop other skill sets as well. So I just challenge you to, as you go back to your office today, maybe start thinking about your staff in terms of those 2 categories of skills and see, what development potential that you might need to be offering to them. And also for yourself, I think that's obviously one of the reasons you're here today. But, as you, as the IT leaders possibly of your organization, need to be sitting more and more at those board tables or at those executive committee tables, what are the skill sets that you think that you need to develop in order to, assist in making those strategic decisions for your organization? And so I remember where we were, meaningful use, stage 1, Superman. I would advocate that stage 2, meaningful use, we've moved to a new world. And we have a fully integrated team of professionals kind of backing up that clinical champion that we really have to rely on a variety of skill sets to get us there. And I did see this movie at the drive-in last summer, and I highly recommend it, by the way. It was a good drive-in flick. Now I want to move from talking about staffing and your feedback on that. I want to move to meaningful use, participation, and engagement, moving into, and this is kind of piggybacks on some of the things that Chris was talking about at the end of his talk, about those alliances and partnerships that we're forming. Not only hospital, physician-hospital, payers, employer groups, all of these relationships that we're developing in different ways really have as a foundational level this data that we're all now involved in collecting and keeping secure. So I wanted to talk a little bit about that, and I wanted to share with you kind of a personal case study, and it involves a tonsillectomy. And I was going to actually put a picture of the tonsils, but I know it's right before lunchtime, so I went with the anatomical outline instead. So about 3 or 4 years ago, I hope you appreciate that. About 3 or 4 years ago, our older daughter had graduated from college, and we brought her home, and she had yet another case of really bad strep throat and was really, not doing very well. And this was kind of something that recurred all during college years. So I'm like, okay, we've just got to get this under control. So I took her to a new doctor, an ENT, and she was sitting up on the table. I was with her in the exam room, and he started talking about, well, she's made it to 20 now, and she's out of that dorm environment, and, we're past all that. Maybe we can just ride this on through. Maybe we don't need to go there with the tonsillectomy. And at that point, he hadn't really examined her. And so he's like, well, let's just look and see. So she opens her mouth, and he's like, oh yeah, these have to come out right now. He knew immediately as soon as he saw them that this was a bad situation. So in my memory, the very next thing he started talking to us about is he started giving us quality data information in the exam room about post-surgical results that he had. And so something to the effect of, X% of my patients over 18 that have their tonsils removed have, a post-surgical hemorrhaging experience. And that compares to the national average of, patients over 18 that have this number. And I was blown away. I was like, this is pretty cool. Of course, at this point, my daughter knows how my brain works, and she's like, man, I wish Dad was here instead of you, because as soon as I hear something like this is where my mind goes, and probably a lot of you as well. Immediately I started thinking about, well, how does he know that? And what reports is he looking at? And how's he determining what information to share in the exam room, and how critical that is? And so this was kind of really the epiphany for me, if you will, of how vital that the business of quality has become in addition to our clinical care outcome, and using that quality in that way, but just kind of the business of how we're communicating about the data. And so if you all have had any experience like that, I definitely think that it's a growing trend, and that clinicians are wanting to use this data more when they're talking about their care levels. And the next thing that I thought about was, well, if he's using those clinical outcome statistics when he's in the exam room with an individual patient, what other opportunities is he exercising to use that data? And so a little bit later, after the tonsillectomy, after she was doing fine, she didn't have a hemorrhaging experience, by the way, so she was one of his positive outcomes in that regard. I did call back to the office manager, and I said, I just had this curiosity, here's why, kind of what I do. And, I wanted to ask her, well, how has this changed, his ability to report like this and talk about data in this way? How has it changed the other things that you're doing day to day in the practice? What about referring, talking to your referring physicians, how the patients are coming into the practice? And I was really surprised. She said, oh, that's not really changed. He just, pretty much talks to the other doctors, the primary care doctors in the doctor's lounge like always. And I was a little bit disappointed, but then I thought, well, that could be so, but once he's gotten in the habit of knowing those statistics and using them in the exam room, it's possible that even if he's just casually talking in the doctor's lounge with his referring physician colleagues, he may still be using those statistics. So I thought that was a positive, possible positive trend. And this goes to, directly to Chris's point about those new alliance relationships. If we have that level of data about, in a physician practice, about physicians and at the hospital level, the volume of data that we have that, you all own, about your clinical outcomes, about all of the meaningful use requirements, that should definitely be exercised, at the board table when you're having those contractual requirement discussions. As Chris indicated, maybe it becomes like, a deal breaker. You either have this, you have that meaningful use attestation report as part of your contract, or the deal's not there. And so I did want to also highlight a personal experience recently with a client project I was on, where we were assessing PQRS readiness for a large group of employed physicians. And when I went to a pretty large cardiology practice, the manager had said, yeah, we've done, PQRI, we did PQRS, we were successful, we got paid. And I was like, well, what about now? Are you still doing it? And she said, well, post-transaction, we had a system change, we had, different things that were going on, and I was just kind of waiting for the hospital to tell me what to do. So I was like, she's just sitting here. She's got the history of knowing how to do this. Her docs were all on board, but the hospital evidently hadn't prompted, or maybe it wasn't part of the discussion. So I would just encourage you, you know, when you hear about, or if you participate at that level about those contractual relationships, to make sure and springboard from their past experience. If they've been doing electronic, if they've been doing electronic prescribing, if they've been doing PQRS, why not make that a requirement that continues post-transaction, definitely? Because that, you know, that definitely falls down to, you know, potential revenue, as well as avoiding penalties from Medicare and other payers. And speaking of payers, not only the governmental payers, but also, as we heard, you know, there's the non-governmental payers that are really getting active in the quality metrics area. And so that's another place where, particularly if you've done this great reporting, if you've got that level of expertise, bring that with you, you know, as a bargaining chip to the table, to say, this is something that we can bring to the payer relationship that maybe you haven't exercised before. And then one more kind of patient-focused opportunity there, obviously, is a website, or your marketing, or how you're reaching out to patients. I do think that there's, and I think it was Mary or Donna that was showing us the Physician Compare website, and obviously there is a Hospital Compare. The data is out there. It's getting out there to the patient base. So where I really believe that we need to, you know, as a provider community, we need to be leading with the data that we want patients to know about. And so that would be another opportunity for that CIO, the IT director, you know, to be part of that organizational team that's deciding, what are we sharing about ourselves with our patients on our websites, you know, or in the patient portal, getting the information out there about the success of the clinical quality data that you've had. And I have just a few more highlights from that survey that you participated in. When we asked, you know, some different levels there, we asked about, you know, are you asking, you know, other referrals or partners about meaningful use attestation? The asking or requiring or not, you know, not currently requiring, those are all about 5%. And then, I'm sorry, or other. The largest response yet there was that they don't currently ask. You know, so nobody's, about almost 85% folks are saying, we're not currently asking people that we're considering as referring partners or alliance partners whether they have attested to meaningful use. And remember, this was a mixture of folks, not only from the hospital side, but physician practice side, so that could be weighting the information there. Another question we asked was about the testing for health information exchange. Obviously, we got a little bit of a reprieve on this in terms of stage 2. You know, it's kind of gone a little bit farther into the future, but I do think it's still very much top of mind, as Mary and Donna spoke to earlier. And in terms of the HIMSS survey, you know, whereas our survey here just indicates, you know, roughly 60% have tested, you know, with 1 or 2 outside entities. In the HIMSS survey, about 50% have participated in the health information exchange. And what I found surprising there is that's in spite of the fact that only 6% indicated that they're required to report. So these are people that are voluntarily doing this testing and figuring out, can I exchange data, you know, with an entity outside my organizational walls, such as a lab, you know, or a hospital to physician, or, you know, just any of those information exchange opportunities. Just a little bit more there about, you know, roughly equal numbers in terms of strategic partnerships. About 40% said yes, you know, that we do have some basis in quality, not necessarily maybe meaningful use attestation, but the starting to introduce quality requirements or quality information into the discussions about strategic partnership. The same, on the other hand, about the same percentage there, another 40% just said they didn't really know. So, I mean, those might be the folks that just aren't at that level of strategic discussion within the organization. But I would just, once again, encourage you to have that awareness going forward. some of the comments on that question, those that indicated yes, that they do have strategic partnerships based on quality, indicated that they had requirements such as patient-centered medical home or other, non-governmental payer requirements that brought them to that place. And what I found encouraging is that they also, said that they were assessing quality alliances for the future. And, just to kind of bring us back to where we are today, and this really, once again, kind of springboards from what we heard earlier from Donna and Mary in terms of some of the really good statistical information they provided for you specifically here in Kansas and Missouri as well, but then also nationwide. So, moving from 2009 to 2012 for the primary care physicians, we've seen, that, 25 to 30 percentage point leap there. At the same time, the quote here from Dr. Goodman, I think says, we still have a long way to go. Basically, we're doing well. We're doing what we need to do to hit the marks, to do the meaningful use requirements. But in terms of embracing, I really think we have to offer practitioners and offer, other strategic partners within the organization the opportunity to see how we're going to use the data. Bring it into the exam room, bring it into the conversation with the partners. And I think that's kind of where we're headed in terms of being just that fully integrated team, ready to go. That is all I have for my presentation this morning. I'll be glad to answer any questions. I think we have a panel also as well, but anybody have any questions about the data or information I provided?
No questions? All right, well, thank you, Linda.
Thank you, appreciate it.